Thank you for the invitation and for the opportunity to present this talk about the novel fluoroscopic approach to impella positioning. I will be presenting this talk on behalf of my colleague and friend Alessandro Beneduce. And so correct impella position is pivotal to avoid device-related complications and to optimize its function. And it requires a multi-parametric evaluation of three basically aspects. One is the correct position and current waveforms on the device console. The other is a correct shaft depth across the aortic valve. And finally, the pigtail should go down deep in the LV apex and away from the lateral wall. When the first two conditions are fulfilled, but not the third, I will talk about impella malrotation for the purpose of this presentation. And the assessment, the gold standard assessment is achieved through transthoracic or transesophageal echocardiography. A depiction of impella malrotation is portrayed in the figure near the three bullet points, and the matching echocardiography is in the right panel. So the clinical meaning of this condition is reinforced by the observation that it is rather frequent. Approximately 1 out of 3 patients in our recent retrospective cohort study featured this issue. And it was also associated with a variety of adverse in-hospital outcomes, including increase in the aortic regurgitation during support, MR increase, and higher rate of major bleeding and stroke during hospital stay. Furthermore, identification of malrotation is not that easy if you leverage only on fluoroscopic images, because the bidimensional image lacks anatomical landmarks and at the same time does not give proper visualization of the LV apex. So if you look at the image in the slide, this impella looks good, looks great, but actually if you add, and this is the same patient, some anatomical landmarks, like in this case you can see that the device pigtail does not go towards the LV apex, but rather towards the lateral LV wall. So at the time being, we place more attention to device orientation. We have identified malrotation as a common issue and associated it with complication. While TTE or TE remain gold standard, they are not always used in real-world clinical practice during implantation of the device. And at the same time, malrotation is not obvious on a fluoroscopy. So we try to find a fluoroscopic approach to help the interventional cardiologist to identify this condition when he's implanting the device. And to do that, and to understand better the relationship between the impella device and the LV cavity, we reviewed the patient who had received a contrast-enhanced, in this case it was a non-ECG gated CT scan during impella support. And you can see that the CT scan gives you a clear idea of what's going on, and you can see that from the left image, the device goes through the aortic valve directly towards the infralateral wall of the left ventricle. And this actually matches an echocardiographic 3-chamber view, and the other image actually matches an echocardiographic 4-chamber view. So luckily, we had also a contrast-enhanced ECG-gated scan of a patient with a properly positioned device. You can see that the pigtail in this case is deep in the LV apex. And again, you can see the 3-chamber and the 4-chamber view. So we have established basically a crosstalk between different imaging modalities, and basically this is the same image taken from different methods. But we focused on the CT scan because CT scan gives you a volumetric data you can use to reconstruct angulation that you can translate into angulation of the C-arm to obtain matching images under fluoroscopy. So starting from the CT scan data of the patient with the properly positioned device, we try to identify which may have been the best implant projection to identify malrotation and to assess device orientation within the left ventricle. Since we cannot hypothesize to make a CT scan for each patient receiving impella, this was just an hypothesis generating case report to identify an average implant projection. And this ideal projection should first of all, avoid Impella foreshortening. And to this end, we identified the radiopack ring of on the 2.5 and CP devices as the marker of choice, because it is a ring-like structure, and when you look at it in plane, you should see it as a segment, like it is in this case, and not as a circle. At the same time, this same projection should avoid the foreshortening of the LV major axis. And again, a ring-like structure like the mitral valve annulus may represent the structure of choice to check if you look at it in plane in the selected projection. So if you're able to find a view that combines and avoids at the same time a foreshortening of the LV major axis and of the Impella device, you'd find the best implant projection. To this end, we use the S-curve approach, which has been described by, among others, Professor Nicolo Piazza, especially for the TA-VR field. And this method uses an automated software that basically tracks the structure of interest and gives you a pair of C-arm angulation that always portray the structure of interest in plane, thus avoiding the foreshortening of the structure. And we applied this to both the mitral valve annulus and to the Impella radiopack ring. And we obtained this result. The yellow, the orange line represents the mitral valve annulus, the blue line represents the Impella marker, and the green line represents the aortic annulus, which we used for quality control of the reconstructions. And if you look at the image on the left, the orange and the blue lines intersect in a right anterior oblique view and a caudal view. It is around 25 to 30 degrees right anterior oblique and 50 to 55 caudal view, which actually is a three-chamber view. And this is probably the view of choice you can apply to implant the device. The clinical meaning of this is that you implant the device in this projection, meaning a right anterior oblique and caudal view, and you observe in this view the Impella radiopack ring as a segment and not as a circle. Probably the device is correctly positioned within the left ventricle. But we can establish also other matches between the fluoroscopic views and the echocardiographic views. If you imagine to flip the C-arm around the orange line of the mitral valve annulus, you will find, we already talked about the three-chamber view, but you would also find in left anterior oblique 10 degrees and cranial 55 degrees as an average projection, a four-chamber view. And again, if you want to further refine the assessment of the device orientation within the left ventricle, you can combine the two views. And the three-chamber would give you an idea of the depth of the device across the aortic valve, of the proper position of the pigtail in the ALV apex, while the four-chamber view basically gives you an idea of the laterality of the device, meaning how close it is towards the septum or to the lateral wall. So you can use this multi-view approach. As a proof of concept validation, we tried to assess this hypothesis in a patient of ours who received the Impella, and we inserted the Impella through standard technique, and then we went to the right anterior oblique and caudal view, and we observed an in-plane Impella marker, and at the same time, in the four-chamber view, left anterior and cranial view, we observe again an in-plane Impella marker. So based on our consideration, this should actually be a properly positioned device. And the first echocardiography we performed in this patient in the ICU actually confirmed the correct rotation of the device within the left ventricle. So to conclude, we have presented a rapid assessment tool that may overcome the lack of availability of ultrasound imaging at the time of the implantation. The right anterior oblique and caudal view may represent on average the preferred implant fluoroscopic view, while multiple views may actually further refine the assessment of the Impella position within the left ventricle. But as this is based only on one patient and actually deviates from current recommendation, it clearly needs further prospective validation. Thank you for your attention.